Hi, my name is Fred Begueras. I'm a sports and spine medicine physician based out of Virginia Beach, Virginia. I wanted to create a series of videos to help understand my practice in particular and some of the procedures that I perform. One of the procedures that I'm going to focus on for today is electrodiagnostic studies. The EMG, or the electromyogram, consists of two separate procedures. The first part is the nerve conduction study, where I use a series of electrodes and place them onto the hand or foot. A signal is then sent to the electrode to help test the integrity of the peripheral nerve. The second part of the study is the electromyogram, where I listen to a set of muscles in either the arm, the lower leg, or sometimes a combination of the two to test the quality and the function of the muscles. The most common indications for an EMG study include peripheral nerve entrapments, such as carpal tunnel syndrome, cubital tunnel syndrome, and also tarsal tunnel syndrome, lumbosacral radiculopathies, and also cervical radiculopathies, and finally polyneuropathies. One of the main advantages of the EMG study is it helps add to the overall diagnostic picture. So as an example, if you have someone with neck and arm pain and an MRI demonstrates a nerve root getting impinged, such as the C6 or the C7 nerve root, that doesn't necessarily indicate how the nerve is being functioned. So even though on MRI, the nerve can be severely pinched by a disc herniation or overall stenosis, it doesn't actually give any value in terms of the severity. Someone can have extremely severe pain from this type of nerve root compression or entrapment, but it doesn't necessarily give us value or a prognosis if there is actual nerve damage. The second indication is to help localize symptoms. So foot drop, wrist drop, the whole differential can vary. For example, with a peripheral nerve entrapment causing a foot drop, commonly the fibular nerve can be entrapped at the hip. You can also have a sciatic neuropathy, lumbosacral radiculopathy, and ultimately sometimes a more central process like a stroke. So an EMG nerve conduction study can help localize, is this a peripheral nerve problem versus something radicular versus something potentially in the central nervous system. The EMG study can also add value in terms of overall prognosis. So if someone has fairly severe weakness, you can gauge how acute the injury is, if there's any evidence of reinnervation, and give an overall functional prognosis based on those factors and their clinical course. How to prepare your patient for the test. The number one thing that you can tell your patient is to not wear any creams or lotions. As I mentioned, the first part of the test involves the nerve conduction study, and we use these very sticky electrodes. It's very natural for people to want to put lotion on as part of their daily routine, but it can actually make the study much longer, because if they have really well-lotioned skin, the electrode will keep falling off, and it can sometimes make the study longer. And in certain cases, it can invalidate some of the values if the electrode is not able to pick up the signal very well. The second thing is to inform your patient that the test can take anywhere between 30 to 60 minutes. So when I mean anywhere between 30 to 60 minutes, it is sometimes unpredictable. If you have someone that has a slam dunk carpal tunnel syndrome, cubital tunnel syndrome, I can pretty much guarantee that it will probably be somewhere between a 20 to 25 minute study, in addition to any history and physical that I'm going to perform. However, if someone has carpal tunnel syndrome, a history of a cervical spine surgery, in addition to underlying diabetic neuropathy, sometimes that complicates the picture, where I have to not only study the most symptomatic side, but I might have to involve one of the other limbs to give context to what I'm seeing in the overall picture. So 30 to 60 minutes is a pretty good estimate. That being said, I do this study with people laying on their back. So the person does have to be able to tolerate being in that position for about that amount of time. It's already not a very fun test, but if it's very difficult for them to relax and be on their back, that can definitely invalidate the study, because if there's the motion from being uncomfortable can cause a lot of artifact, and it can sometimes make the study very difficult to interpret, if not complete. With respect to medications, for the day of the procedure, you do not necessarily have to have patients stop any medications, particularly blood thinners. The needle gauge that I'm using is very, very small, and in the literature, there is almost no cases of significant hematomal formation. Even with the cervical paraspinals and the lumbar paraspinals, it's very safe. That being said, it's not absolutely necessary. Now, the second medication class are pain medications or neuropathic medications such as gabapentin or Lyrica. The test will be positive regardless of how the patients feel that day. I get the sense that some patients come into the test wanting to be the most symptomatic, thinking that the test will be the most positive if they are symptomatic during the time of testing. And that's just not true. On the whole, the test will be positive whether or not they are in pain or not. So if there's any question or you can sense that the patient is wanting to stop taking anything, I would say 99% of the time, they can just continue taking everything. I can't think in 10 years of practice of a single time where I told the patient not to take a medication in order to complete the study. Now, one of the biggest questions I get is, should I refer the patient for an EMG? And this can sometimes be a little bit difficult. The question of being sent specifically for the EMG study versus being seen as a consult first. Now, in terms of conditions, I would say if someone has a history of spine surgery or a significant extremity surgery, or they have some sort of combination, meaning like they have neck pain with arm pain or back pain with leg pain, and it's hard to tell exactly, is it the chicken or the egg that's driving the symptoms? That's sometimes a person that I would like to see as much information about the patient ahead of time, if not actually have access to imaging that has been completed, so I can help design the study. And another patient population to be wary about referring for EMG nerve conduction study is patients who have very large diameter calves or significant amount of edema in the lower extremities. The nerve conduction study in particular, I use these surface electrodes. And if there's a lot of distance between the surface and the actual nerve, whether it be from soft tissue, edema, or sometimes even just frankly dry skin, that's a very challenging patient because I will often get really very low values, if not sometimes even no values. And it can look like an underlying polyneuropathy, but in actuality, I'm not actually able to test the nerves because there's too much distance between the surface and the nerve. The second population I'll mention is people who have very cold feet, folks with peripheral artery disease, Raynaud's syndrome. The temperature of the skin has to be at a certain temperature in order for the study to be valid. When people come in with very cold limbs, it can artifactually make the studies look a lot slower than they really are. So the patients, I will often tell them to keep their socks on, keep their gloves on until the time of the study, because as soon as the temperature drops, it definitely can affect my interpretation of the study, and then again, it can sometimes invalidate the whole thing. Patients with diabetic polyneuropathy are also a very challenging patient population when it comes to the EMG nerve conduction study. If someone is coming in with numbness and tingling in their feet and they have a strong history of underlying polyneuropathy, you can pretty much guarantee there's probably going to be some nerve changes, but the issue is if the person has underlying radiculopathy of the lumbar spine and they have neuropathy, it could be very difficult to tell the difference between the two. So I won't say in all cases, but in a lot of cases, if there's a question of underlying stenosis of the spine or radiculopathy or cervical spine stenosis, I will often want to see the patient first, or at least review the records before committing them to an EMG and nerve conduction study. I find that the patients tend to be a little bit more at ease because they have such a big story to tell that I want to make sure that the study is designed appropriately and I'm not doing any more extra testing than is necessary. That's all I got for you guys. I hope that was helpful and not too long-winded, but if there are any questions about this study in particular, how it's done, I will be happy to field any questions. Feel free to reach out to me through social media or over email. Thanks again for your attention, guys. I'll see you next time.